two folks that I've been dying to talk to about this issue, and they are dying to talk about it. And so I'm excited to introduce Senator Lysing, who is one of the author of Senate Bill 142, the bill to create a commission to study maternal mortality in Indiana. I also have Dr. Mary Abernathy, who is Associate Professor of Obstetrics and Gynecology at Indiana University School of Medicine. And these two ladies are special because, number one, they wrote the bill. And of course, Dr. Abernathy is a subject matter expert on maternal mortality. This is what she does day in, day out. And so I'm really excited to get started. I'm going to give the ladies some time to introduce themselves, starting with Senator Lysing, please.
Well, I'm Senator Jean Lysing, and I represent 7 counties south and east of Indianapolis. So it's a large geographic area because it's primarily rural, and probably your listeners know that those districts, although there are 50 Senate districts and 92 counties, I have all parts of 7 because it's a very rural population, and those are all based on number of people living there. So the average Senate district has about 130,000 people.
Wow, wow. And you have a history that's close to this. You were a nurse.
That's right. Yeah, I was actually a registered nurse, worked for 7 years till I got in the full-time mom business.
Wow, oh yeah.
And then, unfortunately for me, my first husband was killed in a farm accident. Mm-hmm. And so I took over the management of our farm with a couple of employees. And that's really what led me to the legislature. Now, I know that's going to be a big stretch for your listeners, but anyway, I was president of the Indiana Corn Growers Association. Wow. And that led me to the legislature to testify on agricultural issues. And then one thing led to another, and I got talked into running for the state senate. Wow. And so, but I've always been on the health committee, and I certainly appreciate having that opportunity to be on the health committee, as awesome. Well as I am chair of the ag committee, and I'm on 4 others. But anyway, that gives you kind of an idea of how I got here.
Well, we're definitely going to get back to some of that history. Yeah. I want Dr. Abernathy to introduce herself mm-hmm. and kind of what brought her to helping to write this bill.
So I am a maternal fetal medicine physician, which means I did an OBGYN residency, and then I specialized in helping women who have high-risk pregnancies. And the pregnancy can be deemed high risk either because mom has a medical condition, or sometimes even the baby develops a condition like growth restriction or has a congenital anomaly. So all my professional life, I've tried to help women have successful pregnancies. And unfortunately, I've taken care of some women who haven't survived the pregnancy. And so it's something that's very near and dear to my heart. And we were able to call upon Senator Lysing to help us move a bill through legislation to create a maternal mortality review committee.
Right.
I'm very thankful.
And so I remember the story of how I met you. I was actually reaching out to Dr. Boss. I knew that she was an OBGYN mm-hmm. physician, but I also knew that she would be extremely busy since she's the state health commissioner. And she said, let me connect you with, Dr. Abernathy. And sure enough, I connected with you, and turned out you helped in the writing of this bill in terms of the research and just some of the medical knowledge behind that. And I think that was very, very fascinating. I think it worked out perfectly. So a couple questions. I'm going to start with you, Dr. Abernathy. So this whole maternal mortality was something that was kind of on your mind. And you said, let me find someone who's willing to kind of back me as far as the legislature is concerned with this bill.
Exactly. So this all started, a little over 1.5 years ago. So I am on the FEMOR committee, which is the Fetal and Infant Mortality Review Committee for Marion County. And I had always kind of commented and lamented that we need to have this for mothers as well as for infants, fetuses and infants that don't survive pregnancy. Right. We need to have the same thing for mom. Well, Jerome Adams, the former Indiana State Department Health Commissioner, right. had recently created a maternal mortality review coordinator position. And through different connections, because I had always said, hey, we need to have a maternal mortality review committee, I was kind of asked to join this task force. And on that task force, we have people from the Indiana State Department of Health, we have statisticians, we have nurses, social workers, breastfeeding coordinators. And so we kind of started putting our heads together as to how can we can we get this going? Indiana is in this great period of time where all of a sudden we're paying attention to women's health, infant, fetal, and infant mortality, as well as women's health.
Right.
And I think having Dr. Box and formerly Dr. Adams as health commissioner
Right.
has really kind of set that ball rolling, and then having great legislators like Senator Lysing. So oh, I'm sorry.
No, that's all right. Tell us how, when Dr. Abernathy and some of the team came to you and said, we wanted to help us kind of put this bill forward, how did you feel? And being a former nurse, what did that kind of rise up?
Frankly, I was very excited about doing it, but I must admit to you, I didn't realize that Indiana's mortality rates were so high at the time. I have 3 adult children and 8 little grandkids, ranging age from 6 to 17 now. But I'm very interested in, obviously, people having happy, healthy children.
Of course.
And the moms obviously faring as well. So I said, geez, let's go to work on this. And, I do think your listeners probably need to know that our mortality rate for our moms in Indiana is one that we're not proud of. I mean, it's almost twice the national rate.
Right.
And so we have to figure this out. We have to find out why that is in Indiana. And so I'm really super anxious to see what the review committee comes up with.
Oh, me too. And I want to kind of pause there and just talk a little bit about the maternal mortality rate in Indiana. I testified on this bill, which I was extremely proud of. And just from my research, based on AmericasHealthRanking.org, the maternal mortality rate in Indiana is 44th out of 50. And for those who don't know, that's a bad number.
That's a bad number. That is a very bad number. And I think, to be very honest, what I've read says that only some of the southern states are below
comparative,
us.
right?
And so we don't think that we should be in that kind of a category, and certainly I don't. I mean, I think, and why is it? I know people ask me when I was carrying the bill, why do you think it really is? Give me the scoop. Why is it? And I said, I don't know. I think that's why we need the Mortality Review Committee. Maybe it's because 31 of our counties out of 92 don't have inpatient OB services, okay? Maybe we'll find out that that's part of it.
Wow.
Maybe we'll find out that 16 of our hospitals 16 of our counties don't even have a hospital, period. And so you go, oh, geez, how could that be, right? Because if you're from Indianapolis here, you see hospital after hospital,
Right.
and you wonder, what are they talking about? But I know in my district, 2 of my counties out of my 7 have no OB services. So, even then, does that mean that some of those folks aren't getting even adequate prenatal visits, okay? Right. And Dr. Abernathy could probably talk a lot more about the importance of that. But I think that, it's those things that, why wouldn't people,
Right.
be able to get services? Well, it might be a matter of driving, maybe even for the country folks.
And I'm glad you brought that up. So Dr. Abernathy, talk to us a little bit about what that 44 means. What does that number mean? And then why maternal mortality affects, what does it even mean? Why do I need to care as a normal citizen? Why do I need to care about maternal mortality?
Well, knowing that we're 44th out of 50 means that we have double the national rate. And the rate historically in, say, 2011 was around 20, 24. And now recently, even in the United States, it's gone up to 28.
Right.
And we rank about 51, and that's per 100,000 live births.
Wow.
So we have nearly double the United States rate, which we know is increasing even compared to other developed nations.
Right.
So why care? So I would say that you need to care, because if you were in that condition, it means either your mother or sometimes your daughter has not survived childbirth.
Wow.
And there will be some patients that have conditions where we realize they're not going to survive. But in some of the states that have had maternal mortality review committees for a long time, they found out that approximately 60% of those cases of maternal mortality actually are preventable.
Wow.
So in Indiana, on our task force, we've kind of done some quick searching using the birth records, comparing with death certificate data, And it appears that perhaps 20 to 25 pregnancy-related deaths occur in Indiana each year. Pregnancy-related means that either the condition was caused or aggravated, the condition that caused the maternal death was caused or aggravated by the pregnancy.
Wow.
And so that means that there's approximately 14 to 20 women in Indiana who die annually who we could have prevented that death.
Wow.
So from a psychological standpoint, if that's your mother, your child, that's an incredible importance to you.
Wow.
But even from an economic perspective, and sometimes that's how you get people to start paying attention when you talk to an economic perspective. Now you've left a child who has to be raised by someone. Someone has to make that money to raise that child. So it's an enormous expense from an accountability and an economic standpoint.
So I'm going to pose this question, and either of you could answer. A part of the Indiana Minority Health Coalition is just kind of bring some of these health issues to the forefront that predominantly affect minorities. How does maternal mortality affect minorities compared to the general population? And anyone can answer.
Well, what I've read says that maybe 3 to 4 times as many deaths occur in minority populations.
Wow.
Now, maybe Dr. Abernathy can confirm that or say that that's too high. But that caught my attention. And then you go, okay, so why is that? Could that be maybe lack of access to prenatal care? Or, what I thought of Dr. Abernathy, I know I've read before that minority populations a lot of times have more trouble with hypertension or high blood pressure.
Mm-hmm.
So and this would be more of a question from me to Dr. Abernathy. Could that be contributing, to deaths if a pregnant woman from a minority background was already running a high blood pressure, didn't get adequate prenatal care, maybe didn't know how high her blood pressure was, and then she ends up stroking or whatever.
Right. So all of those are reasons.
Yeah.
Dr. Lysing, I'm going to call you that because you
Right.
nailed it.
Yeah.
That's exactly right.
And so that's why we need this committee, though, to really dig in, right?
Right.
And say, what's happening in Indiana? Is that just speculation on my part? Or,
Yes.
No.
I think you've nailed it right on the head. We know from a disparity standpoint, we've seen this for years, that the fetal and infant mortality is 2 to 3 times higher in the non-Hispanic
Right.
Black population.
Right.
And we've always kind of scratched our heads and said, what? And then when you
Right.
look at it, you look at, well, some of them may not have readily access to medical care. And, we try to have, some programs, but we understand in rural areas out in Indiana, and we are a rural state, we have metropolitan areas, but a lot of the deaths, either in infants or in mothers, are happening in the rural areas. And we do see that incredible disparity with the non-Hispanic Black population that Senator Lysing was talking about.
Right.
And along with that, you have lack of access to care, you have, lack of good care that you sometimes just can't get in, even sometimes in the metropolitan areas. And so we think that contributes to it. If a woman doesn't get early and good prenatal care, as Senator Lysing said, some of her medical conditions could be controlled, and she could have a successful pregnancy otherwise. And so if we don't have that good access to care, if sometimes communities don't understand that the importance of having good and early prenatal care, and that can contribute to it as well. So there are many, many reasons that we see the disparity. And again, we see it in fetal and infant mortality as well as maternal mortality, unfortunately.
Wow. I keep hearing infant mortality being brought up. It seems like there's an intimate connection between infant mortality and maternal mortality. And I'm sure you'll agree that we know that infant mortality is higher in minority populations, especially Black minority populations, than they are in the general population. So there was a study done by Moadab et al., and this was in 2016, and they found in their study 4 major things. So of course it's not all inclusive, but these are 4 major things that affect maternal mortality. I'm just going to mention them a little bit and just kind of get your feedback on whether this kind of reflects some of the data that you've read as well. And these are not in rank order, but these are the top 4 things. based on statistical analysis. Gestational diabetes, and that's of course diabetes in pregnancy for my listeners. There's also pregnancies that were unplanned, so unplanned pregnancies. Also, and this shocked me, that maternal mortality was correlated with moms who were unmarried. And then the last one was 4 or fewer prenatal visits, which you touched on, Senator Lysing, how important those prenatal visits are. And that's visiting the physician as soon as you know you're pregnant, just to kind of get things established. So just talk a little bit about these 4 issues and say, do these kind of follow some of the trends you've noticed, especially in your practice, Dr. Abernathy? And do you know if the state is addressing these currently? And I know especially the unintended pregnancies also correlate with infant mortality. What are your takes?
So I would definitely agree with your 4 topics that you listed there. We know that about 50% of the pregnancies are unplanned. And one of the things that Chris Box and the governor has been working on is to make it a priority to make sure that women have readily available birth spacing services or contraception,
right.
so that every pregnancy is a planned and wanted pregnancy.
Right.
And that, we think, is what will make better outcomes. The Indiana Perinatal Quality Improvement Collaborative, which is a state task force, is looking into a reproductive planning task force. And so one of the things that we are tasked with on that task force is to be sure that we identify those areas around the state that don't have readily available reproductive services access. And many times that is usually an OBGYN or a family medicine or a nurse practitioner or a nurse midwife that can provide those services. And as Senator Lysing said earlier, we have about a third of the state that we realize counties, about a third of the counties don't have either a hospital or the healthcare providers that can provide even GYN services, let alone obstetric services.
Oh, wow.
And so that's something that I think the governor and Chris Box, as the state health commissioner, have realized, and they're working with the different hospitals and the different healthcare providers around the state. What do we need to do to improve access for women to have reproductive health planning services readily available to them? Unfortunately, I think the unmarried aspect is something that's prevalent in our time.
Right.
I always try to figure out why that is, but I think if you're unmarried, you usually don't have the social support and the economics of a married woman.
Right.
And so I think that kind of goes along with not having good access to care sometimes, or, you know, if you're unmarried and you have another small child at home, you have to take care of that child.
Wow.
And I understand what your priorities are. And so that's why we have to make it easier for women to access either prenatal care, or if they're not wanting to be pregnant, access reproductive health planning services.
Wow. Any take on this, Senator Lysing?
No, I just think that, you know, when I look at my 7 counties, just that I know best, you know, I know that there are definitely some counties that it would be more difficult for any pregnant woman to get top-notch OB services,
Right.
okay?
Right.
And so I think that, you know, when you look at that, and then I think of just the practicality, kind of following up on what Dr. Abernathy said, and that is, you know, for a woman who is a single parent,
Yeah.
and maybe she already has a child, and she's trying to work, and then when can she get that prenatal appointment? You know, and I probably haven't really researched that even in my district as much as I should, but you know, I don't know that there's a lot of evening appointments maybe available, for instance, if she has a
It's
daytime
in after
job.
work. Oh, wow.
See, and then all of a sudden we go, oh, so is that the reason that maybe the average is only 3 or 4 prenatal appointments versus having 8 or 9?
Yeah.
You know, I don't know. And again, I guess, you know, I think it's going to be very interesting to see what this
This commission.
Committee does, really. I think that, we may have, all of us may have our eyes opened, and I think that there's bad stories from all over the state. I think sometimes we think, it'll just be in certain areas. Why? I don't think that's the case. I think, and if you think about it, some of our smallest hospitals may have, if something goes wrong, they may not have the ability on site to take care of that problem for that mom immediately, and then maybe they could airlift them, but maybe not with our weather. I mean, today you couldn't helicopter anybody because of the wind, right?
And I'm glad you brought up this issue of capacity. A small hospital in rural Indiana, will they have some of the specialties and tools to take care of some of these higher risk moms that may not even know that they're high risk until they show up at the hospital? And correct me if I'm wrong, there was a bill proposed this year to kind of level or rank the hospitals based on level of care in terms of obstetrics and prenatal care. Am I correct?
Yeah, there was. And
that was
did it
passed.
pass?
Yeah, that
I
was
think
passed
it was passed.
and signed into law.
And I think
that
it was
the 360 perinatal levels of care that Governor Holcomb signed.
And was that focused more because of infant mortality, I believe, maybe?
Yes.
But it's going to help everybody.
Right, because of the intimate connection, and also it'll help moms who are high risk, who, as you state, live in some of those counties that don't have these abilities, to say, okay, I'm drawing closer to my due date. Let me see if I can get somewhere closer to whether it's St. Vincent or IU or community or some of these hospitals that have the ability to tackle some of these problems. Wow, this is very much interesting stuff. We're going to take a break in about 5 minutes, but before we take a break, I want us to kind of talk a little bit more about maternal mortality in society. Now, we know that Indiana is 44th. Do you know what states are kind of like top 5 or have an idea of, and I apologize, but do you have an idea of what states?
Senator Lysing kind of nailed it. Southern states, Mississippi, Alabama, those states that are in the deep south that again have a large rural population.
Right.
They tend to be the ones that are kind of top on the list, unfortunately. And where we see some of those things in Indiana, we have a very metropolitan area and some of the larger cities. But out in the rural areas, it's no different whether you're in Mississippi or Indiana. You just don't have access to good quality care.
Wow. And you mentioned that maternal mortality has been rising, and based on my research when I was looking at this bill, it's been going up over the past 10 or so years. Can you talk a little bit about that? Why is that? Are there any trends that you've noted that this is why this is happening over the past 10 years?
So nationally, we've seen that. And one of the states that's been doing it for the longest is California. And they actually, over the past 5 to 7 years, have noticed a significant decline in their maternal mortality rate. And part of that is because they've had this maternal mortality review committee, and from that they've formed this collaborative between the hospitals and the providers in the state. Wow. And they've identified certain things in their preventability category, like how to recognize and deal with hypertension so that it saves a mother's life.
Right.
How to recognize those patients who are at higher risk for developing a blood clot or venous thromboembolism.
Right.
What to do when you have a patient who's at high risk for developing a postpartum hemorrhage or some type of hemorrhage.
Right.
And so they've actually been very successful in getting the word out to the hospitals around the state of California. These are the protocols you need to have in your hospital, have them developed so that if a patient falls into one of these categories, you do A, B, C, and D. And they've been remarkably capable and successful in decreasing their maternal mortality in California.
Wow, so I'm definitely with Senator Lysing when she says, gosh, I can't wait to see what this commission comes forth. Now, I know this question is an immature question, but I'm just going to ask it anyways. Starting with you, Senator Lysing, right before we go to a break. So just kind of make it as quick as you can. What do you think is going to come from this commission?
I believe that when they report back to the legislature every July 1 for the next 5 years, that we will see legislative action based on some of those outcomes and reports. And so that's a good thing. What will be the number one thing? One of the things that comes to my mind is, will we find that drug use interacts with this death rate? And I don't know, but I've had people ask me since I carried the bill, well, give me the real reason. What do you think? Well, I don't know. That's why we're doing the bill.
Right.
But you can't help but wonder maybe if the huge increase in drugs across our entire state.
Right.
And I mean, I have one of my counties is the second county in the state that adopted the needle exchange program because they had such high hepatitis C rates.
Wow.
And you go, oh my gosh, how could that be? But that's such a rural county. Well, I mean, so anyway, I'm hoping that it will give the legislators like myself an idea on what else can we do to help our moms across the state.
Right. What do you think, Dr. Abernathy?
So one of the things I'm hoping to find out is historically when you and I were probably in medical school, me much before you, I think. But anyhow, the three big things we worried about with maternal mortality were hemorrhage, hypertension, and blood clots, or what we call venous thromboembolism, a fancy name for it. And what some states have found out is that cardiomyopathy and cardiovascular conditions, as well as substance abuse and suicide, have kind of started really creeping up and overtaking those three top historical issues.
Right.
And so I think we are going to find that, especially since Indiana ranks so high in the obesity category.
Right.
If we could eliminate maternal obesity or get women to not become pregnant until they get into hopefully their best, physical self,
Right.
I think we would go a long way. But I do agree with Senator Lysing that substance abuse and drug use and suicides have really started to creep up there as well. So we may be surprised that it's not the three historical conditions that we've learned.
Wow.
And that's what other states are finding.
Right. So we're going to take a break here, and when we come back, once again, we're going to be talking to Senator Jean Lysing, author of Senate Bill 142, along with Dr. Abernathy, who was vital and also a subject matter expert on writing this bill. See you in about 5 minutes. Awesome. Do you ladies need some water? Are you guys okay?
I'm fine.
I'm good.
All right.
Yeah.
So, I love this conversation. It's going well. Is there anything special you want me to talk about in our next segment? Anything that you've kind of...
Can we give advice to your listeners?
Oh, yeah, sure. What I'll probably do is reserve the last 10 minutes or so of the segment. So right now it's 5:31, so we're probably going to talk for another maybe 15 minutes, and then the last 5 minutes we just kind of say, if you could say anything, or if you would want people to do anything,
Well,
we'll just kind of do that.
do you think, Dr. Abernathy, and I'm just asking this question, in regard to coverage insurance, I mean, I believe under our Medicaid policy, any pregnant woman can get coverage, right? If she doesn't have her own.
Right.
So
As long
do
as
you
she's
think?
a citizen,
Right.
Right.
So do our moms know that? We know that.
Right,
Well,
that's a good
Right,
point.
and there may be some women who make a little bit too much.
Too much,
wouldn't
and they
qualify.
fall
Kind of like in that gray area
Right,
where...
right,
And
and
they're-
that's what, HIP 2.0 was, and then you even have the marketplace, but sometimes I think with the changes, the marketplace is getting too expensive.
Expensive.
But I think it's in the state's best interest to
Right.
give all moms some sort of
care. Right, exactly.
And sometimes it's a pain, it's a hassle. It's going downtown to talk to, a person who can sign you up, and you didn't realize you
Right.
have to bring this piece of paper, you
Right,
have
all
to
your
bring this
income
tax
documents,
form.
right.
So then you have to make another appointment. So it's a hassle, and I get that. I understand that. I don't know. I can't solve that problem. And I
Right,
don't know that
yeah,
Senator
it's-
Lysing can solve that.
Right, it's
No,
definitely-
That's
we
what
should
my
get it
go-to.
easy.
That's problem.
Yeah,
well,
fix this, right?
What I wanted to talk about a little bit was what was in the bill specifically. I know that the health commissioner kind of appoints kind of specific folks in specific specialties.
Mhm.
Can we talk about that a little bit in the
Sure.
next segment?
Yeah, sure.
Kind of what those appointments are, and are there community stakeholders? When I say community stakeholders, we're talking about that old mom that every young lady goes to, or we're talking about some of those moms who've had a hard time with the healthcare system, or with their children, whatever the case may be. Maybe they had a bad experience. Because I read the bill, but I don't recall some community stakeholders. I may be wrong or right or wrong.
No, and
but I may bring up that issue in the second segment.
Fine. Yeah.
Just because I feel, we have all these stakeholders, including the providers and the administrators, but a lot of times when making healthcare decisions, sometimes we fail to take the patient into account. And in this case, that would be the moms. And so, the bill is the bill, we get that. But I do want to talk a little bit about just those issues where we don't involve the community specifically. I mean, granted, we're talking about all of Indiana, but that kind of changes things.
Dr. Amarantha, do you think that we'll find that our death rate is even higher?
I worry that we will.
I think we will.
Yeah.
And I don't know if
Really?
we can get into
You know
that.
how it's been determined? It's
Mhm.
based on death certificate data.
Right.
I don't know if you ever filled out one of those.
Oh gosh, it's
Exactly,
a beast.
that's-
Number one is a beast, so I try to get it done
Yeah.
as quick as
So
possible.
on the very
That's
bottom of
bad,
that,
but-
on the very bottom of that form, there is a small little
like a
square.
one line, right?
Yeah, it says, has this woman been pregnant, or was this woman pregnant at the time of death? Was she pregnant within 42 days? Has she been pregnant within a year? By the time you get to the bottom of that form, you're like,
You're just ready to go.
I don't know. And I know that happens. I mean, I've done it myself, and so I know even in the rural communities that we have relied from that data to have people fill out that form. That's the
Right.
only way we've gotten that data. And none of that data previously that we've submitted to the CDC that came up with our rate
Mhm.
has been ever cross-matched with a birth certificate from
Right.
a baby. And so that's where I got that
See,
number.
and here's another issue that I may bring up is just kind of, I know that providers in this case have to report to the commission. I had an experience in medical school. A lady came to the OBGYN and, she complained of feminine issues, but then she also said, I have a headache.
Mm-hmm.
And then I looked, and I was a med student, so, I was kind of, all glossy-eyed. And I said to the obstetrician, I said, she also has a headache. And he looks at me and said, what does that have to do with me? He did.
Mm-hmm.
And as you know, we claim OBGYN as primary care. So he may have been the only physician that woman sees for the rest of the year. And so I was just kind of, my heart kind of sunk a little bit. My idealism went down a little bit. But I'm saying that to say maybe there's some providers. Maybe she went to see a psychiatrist or a heart doctor who doesn't even ask if she's been pregnant the last year.
Right.
And never even thought about that. Right. And turns out maybe she ends up dying and he's the one that fills that birth certificate and he just doesn't think about it because it never occurred to him.
It's not uncommon to get a pregnancy diagnosed by a CT scan or an X-ray.
Oh gosh.
Because the radiologist, someone sent her for a study and they're like, well, but there's a baby in there.
Right.
And that's not uncommon to happen even in
Because
this day
they
and
totally
age.
forget about it.
I have a mom in my district that tells me that her daughter who lived in her house had a bad bellyache and they took her to the hospital and she delivered a baby.
And the 8-pound baby.
And the mom never knew it. Now, it's hard, but I mean, I kind of know who these people are, and I don't think that mom was really fibbing. Now, maybe her daughter was heavier than she should have been,
Right.
but I'm thinking, I've been pregnant. I don't think I could have hid that.
Right.
Yeah.
Right.
But you do hear that happening, and I think it usually is in people who are a little obese or
Yeah.
they're obese, they're heavy, they're overweight, and they always wear kind of
Baggy clothes,
Right,
and so
right.
nobody knows. Yeah. The other thing that I worry about, just quickly, is that even with what we've set up, I don't think it's going to take into consideration our out-of-state. Like down at a couple of my counties, the people go to Cincinnati,
Kentucky or Ohio,
and then you get
or
in the far south, they go to Louisville, or in the north.
Chicago,
They go to
right?
Chicago.
And maybe some places in Michigan,
Michigan.
like Niles.
Yeah, and see, I don't think we've even touched on that.
No, and I don't know that we necessarily can.
I don't think we probably can. I
We
think
got
that-
enough issues.
We have enough. We don't have to gather up more, right?
So we're gonna head back on here.
Okay.
Give me a second. I'll be right back. You don't know.
I like it.
Technical difficulty.
Right.
Yeah.
So our next
So I can, you can probably talk about the bill, but I know who's supposed to be on the committee.
Sure.
So yeah, I'm going to talk a little bit about what's in the bill. It's specifically committee appointment. And then I'm also going to address some of the things you ladies just talked about, especially the insurance problem. And then we're going to talk a little bit about the provider issue.
Okay.
That's great.
Good.
We're going to talk about the provider issues where some providers may not even question whether or not this lady's been pregnant. And before we do that, though, I want to define specifically what we say when we mean maternal mortality, which, if I'm correct, it should be a death that is exacerbated or caused by pregnancy up to a year after pregnancy? After delivery, right?
Yes,
Okay.
and that number is per 100,000 live
Per
births.
100,000 live births, okay.
Correct.
And it's during the pregnancy, and then the year after.
I see. So from the start of the
So from the
pregnancy,
start of the
so that's that
pregnancy.
first year essentially, and then up to a year after
Mhm.
delivery of the baby.
Mhm.
Okay, okay, that makes sense.
Fade out.
Hello, Indiana, and welcome back. Once again, my name is Paul Hannum. I'm a policy associate with the Indiana Minority Health Coalition. And just for those listeners just joining us, I am speaking today with Dr. Maripel Abernathy, who is an associate professor of obstetrics and gynecology at Indiana School of Medicine. Also, I have Senator Jean Lysing, who is one of the authors of Senate Bill 142, creating a commission to study maternal mortality in Indiana. And just before the break, we touched some issues on what is maternal mortality. We talked about, Indiana is 44th out of 50 states, and we are comparative to some of the deep southern states. And so in this segment, we want to talk a little bit more about, the bill and get down to some of the nitty-gritty, all right? So one of the issues we want to talk about is access to health care and insurance. And Senator Lysing, I'm going to start with you.
Okay.
Tell us a little bit about insurance and access as far as especially people of lower socioeconomic status and pregnancies.
I want to make sure that your listeners understand that if they want obstetric care, that they can achieve that no matter, if they're of low income by getting on Medicaid, okay? And that will allow them to have those very important prenatal visits and the follow-up care that they need. So I think that sometimes we in the legislature and maybe even our physicians, we all know that, but maybe that young person that's never been pregnant before and
Right.
maybe she's not really happy to be pregnant, maybe she has no support at home with her family, she needs to reach out and talk to someone about how she can get signed up for Medicaid.
So close to the end of our segment, we're going to talk about some areas or places they could go just to even learn about how to sign up for Medicaid, because it may be a daunting process. Talk a little bit about that, Dr. Abernathy, just kind of the access portion of things and the insurance portion of things. And maybe people are just too prideful. They don't want to go on Medicaid. They don't want to be on welfare. They don't want to be on state help. There's a barrier there sometimes, just pride.
Yeah, no, I totally understand that. What people may not realize is that over 50% of our deliveries in Indiana currently are funded by Medicaid. And so it's the way we do business in Indiana in the obstetric line. So I would encourage anyone to apply for Medicaid. Even if you don't get it, they may tell you you would be able to get HIP 2.0, which again, sometimes that's a very, very low cost way for patients or women to get obstetric care. The other thing that's important about Medicaid is it will make things retroactive. It can be a pain to sign up for.
Right.
I've never signed up for it, but I've been told by patients that sometimes it's difficult. You have to ride a bus to go to a different place, and you sometimes, you forgot that you didn't need to, you needed to bring this tax form or this employment history. And so it can be a pain.
Right.
I would encourage everyone to stick with it, if not for yourself, for your infants.
So just to clarify, when you say retroactive, that means if you saw a physician at your first prenatal visit and you didn't have Medicare at that time and now you're stuck with this bill, you can get Medicaid, and say to this physician, now I have Medicaid, you can bill Medicaid for that first prenatal visit. Is that what you're
Yes,
saying?
even more than just one prenatal
I think
visit.
it's 90 days,
Yes, it's
isn't it?
90 days and
I
it's
believe.
retroactive.
Wow,
So
okay,
that's the one thing if women can do is to get prenatal care.
right.
And I think that will go a long way with at least us helping us recognize those women that need more care.
Mm.
And I understand there are barriers to getting signed up for Medicaid. We try to make those, less and less, but sometimes it's a pain. You gotta ride a bus, that bus was late, you missed your appointment, whatever. But that is the one thing that we have found, whether it's maternal mortality or fetal and infant mortality, that really matters is getting into good prenatal care. And that's one of the things that we find with our disparity rate, is
Wow.
that sometimes African American or non-Hispanic Black patients can't always get into a provider. And you may have providers in your area that may not take Medicaid.
Right.
And that's not that uncommon, especially in Indiana sometimes. And so I would encourage people to just continue and don't take no for an answer. Keep calling around until you get the answer you want or understand. And accept that it is something that you need to have is good prenatal care.
So we're just talking about just a little bit of persistence and a little bit of diligence in
A
terms
lot
of,
of persistence
okay.
sometimes. I mean, I'm a healthcare provider. I know
right,
it can be a bother sometimes.
wow,
But a lot of persistence, and don't take no for an answer. Keep going.
roger that. Senator Lysing, I want to come back to you, and I want to talk about some of the things that are in the bill. And you can kind of expound on this. So the health commissioner will appoint certain people of certain specialties to a commission to kind of study this topic. Tell us a bit about that.
There are 17 members,
Okay.
and the commissioner, that Fox, will be the one that will actually designate the maternal mortality coordinator, okay, that will head up. And that position, the maternal mortality coordinator, is a paid position. And so there really is pretty broad representation, but
Okay.
it is primarily those folks that are directly involved in providing care in some way or the other. So you have a person from the State Department of Health, you have somebody from Family and Social Services, you have somebody from the Indiana Hospital Association, you have, I think, 2 members from the local health departments,
Okay.
and hopefully Commissioner Box would appoint, maybe somebody from some rural counties and
Right.
other parts of the state.
Of course.
Then there's somebody for mental health. There's somebody for midwifery.
Right. Right.
Because we still have certain populations that
use, that's right.
would prefer
Especially
that.
the Amish population.
Exactly,
right?
and I have one area in my district that would be like that. And then sometimes there's community mental health, or
Okay.
mental health, but community health services that have OB/GYN care. So I think there's a couple of those appointees. And then I know there's an epidemiologist.
Right.
There's somebody
Genetics,
involved in
pathology,
Really?
social work,
Yeah.
public health nursing. So it's a wide spectrum
Right, yeah,
of representation to try to really distill down those causes that we find and are they preventable.
Right. And of course, I'm sure we have an obstetrician, a pediatrician, I think a family physician as well.
Family medicine,
Right.
yes,
Right.
and maternal fetal medicine.
And I think that it's important to know that these folks that are serving on that are going to be granted immunity. So as they draw in the information, like let's say,
And you're talking about like HIPAA type.
well, more than that even, it would be like a hospital doesn't want to get tagged because they've had, unfortunately, 2 women die there in the last year. Because it could be totally unrelated to anything, at the hospital. So
Right.
there is that immunity that I hope it will allow people to
Want to report.
want to report, to speak freely and as intelligently as they can.
Wow.
When we went to Senator Lysing, we said from the task force in Indiana ACOG, we said we need to have mandatory reporting. So if you have a maternal death in your facility, we want that facility to report it to the Indiana State Department of Health, to the actual maternal mortality review coordinator.
Right.
And so we wanted mandatory reporting as well as confidentiality, so that none of that could be discoverable. And that will improve your mandatory reporting, because then a hospital is going to want to know, what could I potentially do in another case, or to improve or to prevent this from happening? And so those are the two things that we went to Senator Lysing for and said, we really need this from, our task force perspective.
Wow. And that makes perfect sense. You don't want people to withhold numbers and definitely skew the data.
Well, even an individual physician. I mean, it's kind of like when you haven't had any car trouble, and then 3 times in 1 month your car breaks down, right? I'm sure for the physician, you could have gone for years and not had a bad outcome. And then all of a sudden had a couple, and you're like, oh my gosh, do I really want to admit that, that this is what happened?
And speaking of physician, I posed this to someone else the other day regarding this very same bill. We know that physicians already have a high burden or high administrative burden. And Dr. Aben, if you can speak to this, being a physician and having to report a lot of metrics. What is your take on having a physician report another thing? And that's probably how some physicians may look at it. However, of course, it's going to a good cause. It's going to discovering something that we can potentially fix. What is your take on just reporting another thing for a physician to do, report directly to this commission in this state?
Well, luckily, thankfully, it won't be that many times that an individual physician has to report it.
Okay.
And a lot of times, because these deaths are going to occur in a healthcare facility, the responsibility will probably fall more on someone who, other than the physician in that facility, to report. And that's one of the things we're going to be working with the hospitals and the coroner's offices to say, this is a new law and you need to report these deaths.
Right.
But the sheer volume is not going to be overwhelming,
Right.
like doing your electronic medical records is
Gotcha.
sometimes overwhelming. So I don't think that burden is going to be too burdensome for the physician.
Okay, awesome. Now, speaking of physicians, we talk about just providers being aware of moms. During the break, you brought up an example of sometimes discovering that there's a baby in the womb after you take an X-ray or a CT scan. Talk about some providers who, whether it's through the rush of the day or busyness, sometimes just kind of miss asking questions like, have you been pregnant in the last year, or are you pregnant, or is it possible that you're pregnant? Just to kind of do their due diligence, especially when it comes to whether it's harming the baby or the mom.
So, I understand. People are very busy. You have quotas you have to meet. You have patients you need to see, and now you have this added burden of, filling in everything on the electronic medical record, and with insurance, you have to make sure these boxes are checked. So I understand. I think there are several businesses that actually find that there's more work, there's more paperwork that has to be done. So it's not uncommon, as you mentioned, for us to discover a pregnancy based on an X-ray, a pelvic X-ray, or for some other reason, or even a CT scan. It
Right.
does happen. I hope that we can get women to become more proactive and more engaged, to say, I might be pregnant.
Right.
I am late from my menstrual cycle starting, and we need to check that out.
Right.
And so it's not expensive to have urine pregnancy tests either in your office or your emergency room, so that you can very quickly determine, based on even a urine pregnancy test, if she's pregnant or not.
So we're coming to the end of this segment here, but I want to touch on something that is near and dear to me. Let's talk about the whole issue of education. I know Senator Lysing, you mentioned someone in your district who was pregnant and didn't know it until she went to the ER. Some women don't know what to expect when expecting, and sorry for the pun there, but some women don't know. And so they may think, this vomiting episode, I'm just sick, maybe it's something I ate, or, their menstrual periods were irregular anyways, and so, it not coming for 9 months. Yeah, it's just another day, and in their life. What can we say to women to say, you know what, be more in tune, or how can we get them more in tune with their body, education-wise?
Well, I think that women need to be very aware, more aware, and do better planning of their pregnancies, so that if they know they're not in a good situation right now, perhaps they need to avoid pregnancy and whatever method or that they would prefer to use. But I think that sometimes women don't think about all the seriousness of becoming pregnant, and
Right.
not just the responsibility of staying healthy for herself,
Right.
and obviously even avoiding any kind of morbidity, which this bill also tends
Touches,
to
right.
address, something that could linger after the baby's born. But I think that they need to understand that they're bringing a baby into this world. It's a big responsibility. I have 3 adult children, and I was a nurse, and I still wasn't ready, Dr. Abernathy.
Wow.
I have to say this funny story that I think, the first night home with the first baby from the hospital, I was never going to use an ugly, nasty pacifier. And I had my husband struggle through the baby shower bows to find a pacifier because I couldn't deal anymore with, and I wanted this baby so much, and I was old enough to have it. And, then of course I was out in the kitchen boiling the pacifier to get all the packaging germs off of it, right? But, it's a big responsibility to have a baby and to take care of it properly. And even though I was a nurse, I don't think I knew what I was getting into.
Wow.
And the sleep deprivation and all those other things that go on. So I think if I could say anything to your listeners, it would be make sure you're ready to be a mom.
Yeah.
Make sure that you really know the responsibility of it. And gosh, make sure you go for those prenatal appointments and stay healthy during your pregnancy.
Awesome. Thank you. Dr. Abernathy, where can women go? What are some places they can find resources or help, or even, if they want some contraception, where can they go?
So all of the...
I know that's a lot,
Yeah,
but...
so all of the large hospital systems
Okay.
will have offices and or clinics. If you call an office and they say, we don't take Medicaid, don't stop there. Don't take that as a stopping point. Well, I'm just not going to find it today. What you need to do, all of the large hospital systems in the Indianapolis area, and I would assume probably hospitals that deliver babies from around the state, will have opportunity to get prenatal care in those different systems. So call your hospital, call your county health department. And again, don't stop if you meet a brick wall.
Right.
Just keep calling around, and you can always contact Senator Lightsey, and she'll contact me, and I'll say,
We'll find a doctor.
someone.
Awesome.
Call the Indiana State Department of Health.
Right.
If you cannot find a provider, let us know, and we will work with whatever networking, whatever systems. But most of the hospitals will have a clinic. County health departments will have people. We do have, though, about a third of the counties in Indiana don't have OB, family medicine, or healthcare providers that provide obstetric services.
Right.
So, it may be you have to go out of state. And that's one of the things that I think Dr. Box, as the state health commissioner, Governor Holcomb, are working on is how can we get access to care out in those rural areas where
Right.
we don't have it currently.
And I remember Governor Holcomb made a statement at the IMHC day. He said, we're doing so well when it comes to commerce and business in the state. But he said, gosh, if we're short on anything, it's probably how we're doing in terms of health rankings. And it seems like he's very determined to work on the health status of Indianans and Hoosiers. And I'm pretty excited about that, actually.
Yeah.
I'm very excited about
One
that.
of his goals for 2024 was that we would have the lowest infant mortality rate in the Midwest.
Ooh.
And that's a tall
That's a
ticket.
big one.
It
That's
is.
a big one,
It
but
is.
I think we can do it.
I
And
think so.
working together as we have with our legislators, with our Indiana State Department of Health, and we're really trying to get that force mobilized to really improve healthcare access and access to contraceptive services or reproductive health planning. And Senator Lysing said, the one thing I would want to say is, if you're sexually active and you don't have any form of contraception, you have to realize that you're likely to become pregnant.
Right.
And if you're not ready for that responsibility, if that, isn't something that you're, ready to just walk into and say, I'm going to devote, the next 18 years of my life to this child, then I really would encourage women to get some type of contraception or something and start, again, there are Title X clinics around the state, there are other, services that are around the state, and we really need to improve the access so that women don't have to drive an hour or an hour and 45 minutes to get, birth control or some type of contraceptive service.
Any last words?
Get prenatal care, and if you're not wanting to get pregnant, then get some form of contraception.
Senator Lysing.
Being a mom is a big responsibility, and now I'm watching my 3 adult kids, and it just reminds me of how great a responsibility it is. So really think and plan.
Well, thank you, Dr. Abernathy. Thank you so much for being here with us. Once again, Dr. Abernathy is Associate Professor of Obstetrics and Gynecology at Indiana University School of Medicine. Senator Jean Lysing, one of the authors of Senate Bill 142. Thank you, ladies, so much for being on this show. You really just kind of open up the discussion and kind of get some of that information out there. And also just knowing that the legislature is behind Hoosiers and helping Hoosiers be healthier and better overall. Thank you so much.
Thank you.
Thank you so much for being
I
here.
hope that it was what you were hoping
Yeah,
for,
This
right?
is
I don't
perfect.
know.
Guys, it's probably better
We did a
actually.
little prenatal care, we did a little contraception.
We did everything.
Yeah, we did a little, having a baby is a big
Right.
responsibility.
Well, rightfully
and
so,
you know,
right?
honestly, that is one thing that I don't think if
Anybody's really prepared for it.
no,
Oh,
and I would
no.
tell you in our high schools right now, I wish I don't know if you know this, but I have been trying to get
Health
good health
education.
education. Okay.
Yeah. Oh, yeah. That's
And,
right.
and here's the thing, you guys. I am pro-life.
Oh,
Okay,
gosh.
I'm endorsed by Right to Life. I'm Catholic.
Right.
Okay, but the truth is, our kids don't know they're playing with fire,
Yeah,
and they're going to get burned.
yeah.
And when I saw this hepatitis C rates from Fayette County, I was like, oh my gosh, this is a real county. But part of it is big drug use. Part of it, they always are on the high end of unemployment. So you boys, if we don't wear you out from working, you know what happens. One year I said, we need to have work camps for all those unemployed boys, right? So that they're tired.
Right.
And then we can solve all this problem.
Just by getting us tired out.
I couldn't do that on the radio.
I know.
But the truth is, I can see in my district that the high teen pregnancy rates, it's all kind of related. Less performance
Economic
at school.
development, yeah.
So in my counties where things are booming, and when you have 7 counties, even though they're rural, they're all different. I have some counties where they've got signs in the windows begging for help,
workers. Wow.
right? And so
That's
all
good.
you'd have to do is have a little bit of energy, and you'd have a choice. You wouldn't even get stuck with that
Right.
one job.
And
there's a
dishwashing
choice.
or something.
No, exactly. There's choices.
Another thing that I think goes well with health education is breastfeeding.
Yeah.
So,
yeah.
with
We'll
my
have to have
experience,
another talk about
Oh,
that.
God.
we
I got
could.
somebody, yeah.
I breastfed all 3 of my kids, and
Oh,
I did
gosh.
it when, if you go back in years, my mom breastfed, but then there was a big taboo, everybody used bottles.
Right.
You're supposed to
And
have
so
bottles.
one of
To
my,
have smarter kids.
Yeah.
You're supposed to use
Oh, yeah.
bottles.
So-
Only poor women breastfed.
exactly. So then one of my best friends in nursing school from Good Sam in Cincinnati had a baby a year before me. And we visited, whatever, and she said, you gotta breastfeed. And I said, oh, I don't know if I'm gonna do that. She goes, you're gonna do it. And I'm good. If you have any trouble, you're gonna call me. Anyway, and I thought it was amazing. I even figured out how to go back to work
Yeah.
as a nurse and do it. And this was when people really, I'm 69, okay? There were a lot of people in that age range that thought it was taboo.
Yeah,
To breastfeed,
yeah.
right?
Oh, yeah.
It was too kind of ancient.
And
Yeah.
that's something that.
And it also helps
Yeah.
with
Infertility,
Planning,
yeah.
Right.
somewhat.
But sometimes some in the African American community, they don't want to even consider breastfeeding.
Oh, I know. And my
Is that
experience,
right?
based when I was in South Bend, I would talk to some of these African American moms, and they'd say straight up, "I don't want my baby sucking on my titties."
Yeah. Oh, yeah.
And I'm
Yeah.
like, wow.
It's kind
So
of.
it's
yeah.
totally switched in their mind where
Now,
the
there
breast
is
is
a
not a.
Central Indiana African American Breastfeeding Coalition, and
Is
that's
there?
who you need to get on this
Oh,
program.
that would be.
And Kathy Detweiler, the Indiana State Department of
Yeah, you
Health.
had to
You
take
can-
that.
Can you send me the?
Yeah,
this information?
I'll send you Kathy's, and she'll
Okay.
know who the
Who the-
exact person
okay.
is,
You
and
really
get both
do.
of those.
Okay.
Because that's the community, that we have this
Oh, yeah.
disparity. But like you said, I walk into a patient's room and she's like, "Oh no, I don't
Right.
want to breastfeed," and I'm like, "Oh, come on, think
Right.
of the antibodies,
Yeah.
think of the protection for
Right.
the baby."
Yeah, but see, by the time my daughters had their babies, then it was okay again.
Yeah.
You
Right.
know, they weren't,
You're
Socially-
bad if you don't.
yeah, they weren't socially, like,
Right.
Really?
But-
You're
but-
gonna
but
do that?
We also need to ask, how information is disseminated in this country. It's really disseminated through kind of social media and the media at large.
Mhm.
And you never see women breastfeeding, not on TV, not on social media, not in books, nowhere. You don't see it. They don't
Yeah.
talk about it. They don't. And so you got to wonder, gosh, so when moms get to that stage, it's just not
do
something
you
you're
know what
familiar with.
percentage of moms today breastfeed? Because
Well,
I don't know.
No, it depends on, are you talking
And
about
about for 2
breastfeeding?
months,
Right.
or
2
for doing
months,
it for 9
going
months.
home
Or the
for
recommended
9
1
months.
year, right?
Right, so we think that in different hospitals will have different statistics, but somewhere between 60 to 80% of women will say they're gonna breastfeed when they're discharged at home.
Mm-hmm.
Now, when you look at 3 months and 6 months, it starts dropping off very precipitously after that.
Yeah, and I remember my one daughter having a nurse Cratchit, what I'm called, in the hospital. And I mean, thank God I came to see her right away, and she was telling me all the, and I said, hey, let me tell you what to do. I'm your old mom.
Right.
So in her case, she probably would have quit
Right.
because of Nurse
Because-
Cratchit,
right.
who wasn't giving
Oh,
her
wow.
any tips, ideas, whatever,
Right. Right.
And,
And I've said breastfeeding is the second hardest thing I've done in my life. So it's not always easy. They don't come
Wow.
out like puppies and just
Right.
figure it out.
No,
And
exactly.
sometimes it's
Yeah.
like teaching a